Good morning. Every single one of us wants good care if we are ill for either ourselves or our loved ones. And I'm hoping it's not too early to start a bit of audience participation. So I'm going to ask you to put your hands up if you agree with this statement. Kindness and compassion cost nothing. Hands up. Okay. I'd say that's a small but majority. And that's a very understandable belief, and it's a very popular belief. And it's understandable unless you recognise the concept of emotional labour. Emotional labour was a phrase coined by Hochschild in the 1980s, and at its simplest, it means managing your own feelings in order to present a work-appropriate emotion. So if you apply that concept to nursing, that means remaining calm and caring when you're being spat at by a patient when you're trying to change their clothes. It means sitting with a patient who's dying and dealing with their relatives and trying to be in the moment with them while reliving your loved one's bereavement recently, managing your own grief, suppressing your own grief in order to manage the grief that's in the room. That is hard emotion work. And that is the essence of nursing. Menzies was a psychotherapist that was invited into a London teaching hospital in the 1950s. She was asked in to help them with the high attrition rates of student nurses. And she made an observation about nursing, and she said it's a series of disgusting, distasteful, and frightening tasks. Now, I've been a nurse for many, many years, and I'd never heard it described in those terms. But you know, there's more than a grain of truth in that. Now, clearly, most nurses do not consciously or subconsciously consider patients a series of unpleasant tasks, and they would do their utmost to protect them from that concept. But think what that might cost them day in, day out to provide compassionate care in order to protect their patients from this. I watched a documentary a few years ago where a nurse was behind the curtain and she was changing a patient's colostomy bag. And she came out from behind the curtain and the narrator followed her to the sluice where she was spraying perfume. And he said, "What are you doing?" And she said, "Well, I don't like doing this. It's a horrible job, but I don't want my patients to know this. So I just come in here, put some perfume on, I feel better, I can go back out and start caring again." In my first 6 weeks as a student nurse, I was mostly sobbing in the sluice. Can you imagine how helpful I was to the rest of the ward? And that is because although I knew, or thought I knew, what being a nurse was all about, I was absolutely not prepared for the levels of human misery, anxiety, decay and distress, and I was literally overwhelmed. And when we become overwhelmed, let me just talk to you about the difference between kindness and compassion first. Paul Gilbert differentiates between kindness and compassion by describing kindness as being something that you do, like buying a gift for somebody or taking them shopping. It's actually pleasurable. You both get a nice warm feeling. Whereas compassion involves being engaged in somebody's suffering and distress, trying to relieve it, but nonetheless being there with them. And that can often be unpleasant. This clearly can't be done from the sluice, so I had to get myself out of there. But it does require a withdrawal from your emotional bank account. You have to dig deep in order to give and carry on giving. And like any bank account, it can become overdrawn if it's not topped up. When you are running on empty, self-protection kicks in. This means you can develop an unhealthy detachment. You stop hearing the buzzers. You don't meet the eyes of patients lying on trolleys in A&E. You don't look up from the nurses' station despite there being a queue of visitors. You avoid their demands for fear of being overwhelmed. Youngson describes this emotional detachment as the only survival strategy. Now, some of you might be thinking this is namby-pamby hug-a-nurse rubbish, and if we just went back to the good old days of recruiting those caring nurses and stopped over-educating them so that they weren't too clever to care anymore, all would be well. Well, the flaw with that rationale is that you're assuming compassion and intellect are mutually exclusive attributes, which I, for one, find personally offensive, and also that good care always happened previously, and that's just not true. Of course, poor care can't be condoned, and we need to find ways to ensure that care is given well. But in our quest for solutions, what we quite often get sucked into is blaming individuals, and that is really satisfying and seductive because the solution seems so simple, you just get rid of them. And of course there are bad nurses. Just like in any profession, there are people that shouldn't be there. But our work indicates that that isn't the prime reason behind the failures in care that we have sadly experienced in the UK for over 40 or 50 years, from 1960s when the Eli Hospital scandal broke, right up until Mid-Staffs and Morecambe Bay today. And an inquiry after these scandals is always commissioned. The idea is to find out what went wrong and to stop it happening again. Action plans are developed in response to the recommendations. And if that formulaic response did work, we've been doing it for a number of years now, then would it happen again? Can we be sure it won't continue to happen? Our view is that an overlooked factor is understanding the complexities of care and what it is, the needs of our emotional carers. When we employ nurses, when organisations employ nurses to deliver emotional labour, that is a role requirement. That means, like a chauffeur has to be able to drive, and a French teacher has to be able to speak French. The organisation has to understand this requirement and what it is that it is expecting its workforce to do. And it needs to pay attention to supporting them in order for them to be able to fulfil this responsibility. You can't leave that to the individual alone. The organisation needs to recognise this emotional bank account gets overdrawn as much from the cumulative day-to-day stresses of caring as it does from the heart-wrenching events of a road traffic accident or a sudden death or a child tragedy. And attention needs to be paid to helping people top them back up. If we think about physical labour and the risks involved with that, that's really well understood. Organisations provide hoists for nurses to use in wards or in patients' homes to make sure they don't hurt their backs. But emotional labour is not on the health and safety agenda of any board I've ever worked on. Caring is just seen as something that is easy to do if you're that way inclined. If you're a caring person, it's just easy. One organisation that understands its responsibility to emotional labourers is the Samaritans. They ensure that their volunteers work in twos and they're buddying up. So as they're taking calls on their helpline, their job is to look after each other as well as the caller, some of whom are very, very distressed. And in between calls, they just check out with each other that they're okay. And if they think they're not, their buddy will say, let's turn off the phones, let's have a proper debrief. Now, of course, it's inconceivable to think that any frontline NHS service could be turned off, even momentarily, although they can divert the calls in the Samaritans. Even so, you couldn't do that. But what I think is fascinating is that the 4 Samaritan branch directors I spoke to could all only recall on the fingers of one hand in any given year when they'd had to do that. Because that authentic, genuine offer, we know what this job takes from you, we value you enough to put you first, tops back up their emotional bank account and they can get to the end of the shift. And at the end of the shift, they have to ring their team leader who is off-site, who talks them through the calls and how they're feeling. And if they're concerned about them, they'll continue to follow them up until they think that the debrief is complete and the person is okay. Compare that to the experience of a nurse in one of our research sites recently. She had tried to save a man who died, he bled to death. I'm sorry, I know this is early in the morning, but she then dealt with the gory aftermath of this distressing death. She spent time with the relatives, she laid out the dead body, and she left that ward without anyone asking her, "Are you okay?" She was expected to turn up for work the next morning as if nothing had happened. Whilst it is counterintuitive to say that nurses and other healthcare professionals may need to be valued and supported against this backdrop of a public outcry of failures in care and moral outrage, then maybe we need to think again and consider what Jocelyn Cornwell suggested. She said, when we ask ourselves how anyone, especially a nurse, can ignore a dying man's request for water, we should also ask ourselves how anyone, even a nurse, can continue to give compassionate care day in, day out to frail, very sick, often confused and incontinent patients without excellent support, development and training. So I hope that I've managed to convince you, at least some of you, that kindness and compassion commands a hefty bill. And our mission is to try and find ways to help good people deliver good care. Thank you.